you want to, if you do want to comment on something, please drop it in the chat and ADPC staff will make sure to log that and circle back around to you at the end. Um, we have some policies and controls in that only allow the public to unmute during the public comment period. And as always, we'll get started with our roll call and I'll pass it off to Director Dolph.
Thanks, Tony. Happy New Year. All right, roll call. Caprice Mousy is up first. She's absent today. Caroline Cruz, I think, is joining a few minutes late. Debbie Jones.
Here.
Thanks, Debbie. Commissioner Davis.
Present.
Eric. Commissioner Fuller.
Here.
Erica. Commissioner Pena. Is Fernando here yet?
I'm here.
Thank you. Commissioner Hupy.
Here.
Thank you. Commissioner Mines. I see Julia.
I'm here.
All right. Thanks, Julia.
Okay.
Commissioner Jokinen.
Present.
Thanks, Katie. Commissioner Minty.
Here.
Kelly. Commissioner Alden.
Here.
Ramirez. Commissioner Knudsen.
Present.
Commissioner Loeffler. Let's see Moxie yet. Commissioner Obiero.
Here.
Mike. Commissioner Dorsey Martin.
Right here.
Sharon. Commissioner Marilla Simmons.
Present.
Hey, Shira. Commissioner Antoniadis. Stacy.
Here.
Hey, Stacy. Commissioner Lynch.
Here.
Tim. Commissioner Vesna.
Here.
And Commissioner Nordike. I don't see Vanessa yet. Senator Reynolds.
I'm here.
I don't think we have anyone from Representative Sanchez's office. I think they were busy with LFO today. Judge Ringmaiden.
Here.
Judge. And it looks like Moxie joined. Moxie. And then I think we have Krista Jones here for Ebony.
I think Ebony's here as well, but yes.
Yep.
Oh, great. Okay, great.
Yeah,
We have both of you. Wonderful. Fantastic. And then I think a regular guest today, just want to call, I think April Roman is here with us from the governor's office. All right, Tony, roll call is complete.
Okay, thank you. So for today is our first meeting with our new commissioners. That's sort of official. You know, last time we welcomed everybody, went over playlist and other exciting stuff, which I think was great. And I had the opportunity to meet a lot of the new commissioners. So thanks for making time to meet with me and Annalise. Generally, how our commission agenda is constructed is we start off with a director update, and then we'll usually have some informational type sessions that come in. We'll do our standard committee reports, and then we'll have sort of anything that needs voted on, usually after that, and then we'll open it up for public comment. Today we got a director's report, as always. We have Tim from Third Horizons, who's going to provide us more of a federal snapshot of the impacts of HR 1. We got a few updates related to February's legislative session from Senator Reynolds and our partners at the OLCC. We'll go over some proposed bylaws updates related to committees. And then we'll also need to look at 2 new committee leads for a commission vote. And then we'll end with committee updates and public comment. And I will pass it over to you, Annalise, to kick us off.
Thanks, Tony. I think we can go ahead and take the agenda down. We just wanted to show that to everybody. We have a lot on the schedule today. And I have some kind of administrative updates for you and a couple of big updates during director's update that will require much more conversation than we can have just in the 10-minute update today, but want to make sure that folks are up on kind of the latest things that are happening. And so just prefacing this with that, for those of you that see our playlist in the chat, it is a playlist on YouTube, which we determined was universally accessible with a song representing the first album purchased for every commissioner. So something a little fun we put together for our commissioners. We do not endorse any or promote any song lyrics or could be inappropriate videos. I will just say over time, we don't endorse those. It's just for fun. So staffing updates real quick. We are in the hiring process for our executive support specialist position. As folks know, Karina Vasquez left last fall. And so I've been your board administrator for now. So hopefully we will have that nailed down. Probably the person won't have started, but hopefully we will have somebody in mind by the time we meet next month in Salem. Comprehensive planning stuff. We don't have really a whole lot related to that on the agenda today, but we have finalized our executive summary and the community engagement report. Those are both up on the website. Stephanie has launched the very exciting new website that has for you the comprehensive plan built into each committee's page, along with some data. So we'll be continuing to update that and maybe spend a little bit of time next month kind of showing you what's at your fingertips there. But we had so much today, we wanted to just kind of keep rolling. We also did, just so folks know, a plain language summary of the comprehensive plan. We thought it was important to keep the kind of technical executive summary for all of you and legislative audiences, policymakers, but also to have a plain language summary. So feel free to use that with folks and continue to suggest to us your communication needs for communicating about the ADPC and our work. Legislative days are this week, January legislative days leading up to the short session in February. So we will start to see this week some summaries of bills being rolled out. In order to prepare for that, we have some updates for you later in the meeting from Senator Reynolds. Our partners at the OLCC are going to talk a little bit about some anticipated legislation related to ready-to-drink cocktails in grocery stores. And we're going to hear a little bit from the governor's office later, potentially about behavioral health talent council work, but also the governor's executive order. Which is my first kind of big announcement that I want to make sure everyone is tracking. On Friday, the governor extended her executive order related to homelessness and really honed in on homelessness and behavioral health. And I'm really just going to leave it right there for now. And April's going to say a little bit later in the meeting, but just want to make sure that everyone is tracking that. And as they move through implementation, we'll continue to work closely with the governor's office on that intersection that we're all very well aware of. And then my final update is it's a bit of a big one. The settlement board, I think I mentioned to everybody last month, this Wednesday, we are having an in-person summit in Salem to talk about our budget allocations for the upcoming year for the rest of the biennium. And working with OHA, we've identified a known gap that OHA is going to be communicating about today. I think hopefully everybody in this room knows, and our new commissioners missed the benefit last year of some deep dives that we did on the revenue that supports the substance use disorder system in Oregon. But I think you all know, whether you were here or not, that cannabis revenue is a very big piece of funding for our substance use disorder specific system in Oregon. And cannabis revenue is quite volatile. The price continues to go down. And because of that, there is a gap in funding between what OHA thought they would receive for Measure 110 Behavioral Health Resource Network grantees and what they're going to receive. And so the settlement board is going to consider on Wednesday perhaps mitigating that gap by allocating some settlement board funds. So I'm sure that's going to be kind of a big thing for the grantees in our communities, for all of you and your practice. So just wanted folks to know that there's going to be communications on that, again, coming from OHA later today about the potential reductions to the burn grants. And then the settlement board meets on Wednesday, and we'll see if we can kind of help close that gap to some degree. I think I see Krista and Ebony are here today. We were going to kind of have a conversation. I think we had invited you all to come today to talk about that, but that wasn't going to work out. So if anybody has any quick questions, I think it would probably make sense to have OHA answer questions next month, since we didn't put time on the agenda for that today. But if folks have quick questions or want to know kind of where to go for more information about the settlement board or the burn announcement, I'm happy to take just a couple quick questions before we move on to Tim's presentation.
What is the M110 funding gap with the new projections?
So Krista, I saw you came off camera. I'm happy to answer, for you going into Wednesday. I think OHA is trying to get as precise as possible.
Yeah. I mean, well, actually, we are, and we'll know that figure actually at the end of the day. So I can't answer that at the moment, but we'll definitely be able to give a full update in the next meeting. So again, we're working on trying to explore options where we have kind of a diversified approach to trying to rectify or mitigate the gap. And so we'll know more. We'll have a final number before we present.
Thanks, Ebony.
So Ebony, sound good for us. If the commission's cool with it, we'll collect some questions and from commissioners and then try to send them to you ahead of time. That way you kind of know what we're going to be asking and have
Perfect.
And have you come next commission meeting. That sound good?
Okay, sounds good. Thank you.
Okay, back to you, Annalise.
And that is all that I had. So we can go ahead and shift over to Tim.
All right, Tim, you ready to go?
I am indeed. Good afternoon, everyone. For new commission members who I haven't had the pleasure of meeting, my name is Tim Rourke. I'm a managing director at Third Horizon. We're an advisory firm that's been working with the ADPC in the development of the comprehensive plan. So it's a great pleasure to get a little bit of FaceTime with all of you one more time, including new members. We're also going to be working a little bit with Wes and Debbie, continuing into this year relative to the prevention strategy around House Bill 3321. So we're a group of people that will continue to be in the orbit of the ADPC for this year as well, and we're very excited to do that. I was asked by Annalise and Tony to provide you all an overview of HR1, and as Tony said, a bit of a federal snapshot around some things that are coming down the pike that will impact substance use disorder services in the state of Oregon. So what we thought we would do is I'll just take a little bit of time to walk through HR1, which was known as the Big Beautiful Bill, and walk through a couple of the highlights of its impact on substance use services, both nationally and specific to Oregon. Certainly, there'll be a window of time for some questions if folks have them. Definitely agree this is something that situational awareness is really important for all of you going forward, because there will be impacts on the provider community, on individuals who are seeking care, as well as to OHA and other state agencies who need to navigate some of the impacts of some of the changes in the bill. So with that, I'm going to throw up a presentation here, and I'll run through it and then take some questions. Can everybody see my screen okay? All right, got some thumbs up. So, and we've had some connection. I'm on the East Coast, for those of you that I don't know, and we've had it's a bit of a windy day. So I'm going to shut my camera off as I present just to make sure I don't lose connectivity. But please wave if you suddenly stop hearing me, and I'll hopefully get back on. So we're going to talk about again HR1, which is the big beautiful bill. It was passed by Congress last year. It has a significant, it's an omnibus bill or a Christmas tree bill, which means it's got a ton of stuff in it on a number of different horizons. We're going to stick really closely to its impact on substance use services, but it has impact in other areas that will certainly have consequence to the citizens of Oregon. But we're just going to talk about its substance use impacts today. So why this bill matters? This bill matters because at a high level, it makes really significant changes, in particular to Medicaid. And Medicaid in Oregon, like in many other states, is a dominant payer for substance use disorder treatment services. And so some of the changes that are here could potentially have a really outsized impact for folks who are on Medicaid. There are also, which we will talk about, some implications in commercial insurance as well. So even those who might have private insurance or insurance through an employer are going to see or are seeing some impacts of this bill, which I will touch on because certainly they will impact those who are commercially insured who seek substance use treatment as well. The changes affect coverage, it affects the financing of the delivery of services, and it directly affects provider operations. And we're going to talk about all of that. I want to preface by saying a lot of what I'm going to talk about is probably bad news or news that is a little cautious around some things that are going to be really challenging for the field. But there are a couple of other elements that are actually not necessarily negative that we'll touch on as well to know what's coming down the pike for you all this year. So let's hover first on Medicaid. Probably the most significant impact that folks have been thinking about or hearing about a lot is that beginning in 2027, Medicaid will have what's a work requirement. There has been efforts to put work requirements in Medicaid at the state level in several states across the U.S. Very few examples that have been implemented with really any significant track record in them, but this will become a national requirement in 2027. What's important relative to behavioral health is that although there is a Medicaid work requirement that will get underway and go into effect, there is an exemption in HR1 around folks who meet a qualification for something called medical frailty. And if you meet the qualification of medical frailty, you are exempt from the work requirement. There are a list of conditions that need to be met in order to meet that exemption. One of them is having a substance use disorder or a mental illness. So, on the one hand, the work requirement impacts may be mitigated for those who have a substance use or mental illness issue. However, that definition of medical frailty is likely to be left to states. CMS is delivering guidance. There are states who already have medical frailty language in their state Medicaid programs that incorporate or include ongoing behavioral health conditions as an exemption. But they are different state to state. And so what we are aware of is CMS is going to provide guidance to all states as to how they could potentially define medical frailty, elevating some models in different states. In our analysis, we did not find Oregon having a definition of medical frailty. Now, given that you don't have a work requirement, that wouldn't entirely be a surprise. But if you do not have one, or if you have one and it does not include an exemption for substance use or mental illness, Oregon would need to adopt or change its exemption or create a new exemption to ensure that those patients would not be adversely impacted. The other piece I would just say around this work requirement exemption is how that gets activated, at what point someone could claim an exemption, not just the qualifying indications, but the administrative process around how you would file for an exemption is entirely up in the air. So that becomes part of, I think, another challenge that's going to come out of HR1's Medicaid regulations around this next piece, which is verification and just administration of being eligible for Medicaid in a given moment. So, folks may be aware if someone is eligible for Medicaid, typically they have to go through what's called a verification process even after they're enrolled. And that is to determine that they continue to qualify for Medicaid in an ongoing way. In most states, that verification process is done annually. However, in HR1, that verification process actually shrinks and requires verification every 6 months if you're in the expansion population. So, what that means is for a number of individuals who are on Medicaid, rather than just the once a year renewal of their Medicaid eligibility, they'll have to go through a renewal process every 6 months. As you can imagine, that has incredible administrative burden impacts on state agencies that have to go through that verification program that process. It also creates another administrative hurdle for individuals who are on Medicaid. And it's been a concern for many advocates in that additional verification or added steps to the enrollment process for individuals could create administrative burden and confusion that might lead people to lose their coverage even if they are eligible for Medicaid. The other element that comes up is that retroactive eligibility has been reduced. So in most territories, there is the ability to, if someone applies for Medicaid, they can apply retroactively for, say, in New Hampshire, 6 months. The retroactive eligibility going forward will be reduced, probably in some instances, to 2 or 3 months. So that means that an individual will have less opportunity, or a provider, if someone comes in who's been providing services who is Medicaid eligible, your ability to retroactively bill will be reduced because of the reduction in that retroactive eligibility that is covered by HR1. Couple of other pieces that are important. All in all, there is increased administrative burden in the tracking of Medicaid. That burden is going to fall to states, it's going to fall to providers, and it's going to fall to individuals. There are a lot of provisions, particularly at the state level, around increasing auditing requirements for states. Congress has been concerned about fraud and abuse within the Medicaid program. So HR1 puts in additional auditing requirements for states to provide financial and auditing reports to CMS to ensure that fraud and waste is being reduced within state Medicaid programs. It's unclear exactly what those audits will entail beyond what they do right now. However, what that likely means is, in addition to whatever additional reporting or data analysis states are going to have to do, it is likely that that may translate into additional reporting requirements for providers who are who bill Medicaid at the state level to report into the state, so the state can meet those additional reporting requirements. All of this, right, is going to lead to what we call churn. In addition to the administrative burdens at the state, local, and provider level, you have changes to eligibility and the cadence that people can apply and need to be verified for eligibility. There is an anticipation of a lot of people, as I alluded to earlier, losing coverage, not necessarily just limited to those who authentically no longer meet the coverage requirement, but potentially those who are Medicaid eligible, but they either miss the reporting requirements or are overburdened and don't submit the necessary materials at validation, for instance. What does that mean to providers? That means increased in no-shows. That means treatment loss, mid-treatment coverage losses for folks who might be in active treatment. Again, even though there's going to be provisions that will allow folks in substance use treatment to qualify under medical frailty, there will probably be some sort of administrative process to demonstrate that. So providers could be faced with instances where individuals temporarily lose their coverage and there needs to be some work to get it back, which has all sorts of implications from provider administration and the delivery of care. The Oregon Primary Care Association estimates that between 100,000 and 200,000 Oregonians are estimated to lose coverage because of these changes within Medicaid. So what we anticipate then, obviously, as a direct consequence, would be an increase in uncompensated care across the healthcare spectrum, not just in behavioral health. And potentially, because people are uninsured again, an increase in the utilization of crisis oriented services. So, to the extent that in the substance use and behavioral health arena, we've seen people improve access to care because of expanded coverage, we might see an increase in people showing back up in crisis situations, in mobile crisis units, in emergency rooms, et cetera. There are also implications for providers. And so one of them is a tax cap that is going to be put in place that does impact providers in the state of Oregon, that reduces the tax from 6% to 3.5% by this federal fiscal year. So that means a potential loss in revenue and a loss in funding. Oregon is estimated to lose over $600 million during federal fiscal year 27 through 29 because of this this tax cap reduction. What does that mean on the ground? It means that CCOs will feel increased pressure on rates and on coverage. So, how Medicaid manages that in states is an open question. There could be reductions in rates or reduced rate setting. There could also be coverage gaps. We've seen some states who are dealing already with challenges in their Medicaid budgets begin to reduce covered services while still trying to stay on the right side of parity. But we certainly do expect that there could be a real challenge in the ability of Medicaid to viably support a broad swath of behavioral health and other services going forward if these kind of reductions come to pass. Couple of other things that are going to happen, again, that impact both providers and individuals. The first is there is also within Medicaid cost sharing that will begin. What that means is in most states, there are no copays for Medicaid, right? There's an effort to make sure that Medicaid covers people without having to create an outsized economic burden on individuals with copays and things of that nature. There will be cost sharing requirements. So again, for folks who are on Medicaid, for whom their economic picture is not strong enough, that could again be another driver to people leaving care or leaving coverage because they can't afford those cost sharing requirements. We definitely anticipate, and this will segue into some stuff that's happening on the commercial side, but obviously, as people get into the workforce and get better in terms of health, there is always the hope, right, that people move from Medicaid into commercial insurance or into the marketplace. Some of this is going to create some challenges with that, and even if someone may no longer meet criteria for eligibility for Medicaid. However, they might meet eligibility to get commercial insurance, as we're about to talk about, and I'm sure you've heard in the news, there are challenges with access to commercial insurance through the marketplace that I think are concerning for folks that might make that transition even harder, particularly for this population. And then again, we see all of this again, a theme that for those in treatment, for those seeking treatment, these things could create a snowball effect that we might see real challenges in people's ability to sustainably engage in treatment, particularly long-term treatment, where they may bump up against these eligibility and other things that might get in the way of continuity of care. A couple other things I want to mention on Medicaid. First, and this is not to suggest that Oregon does this, but it's important across the healthcare continuum. Many states, when looking at innovative services, will look at this idea of directed payments. I know in my state, I live in New Hampshire, directed payments have been an opportunity for the state to innovate within Medicaid, particularly around behavioral health. So in this instance, these are services where it might not be part of the state Medicaid plan, but a state will determine that they want to have a new benefit in Medicaid. So what they will do is they will create what's called a directed payment, and the state will pay directly for that service. It's in some instances, it's more efficient to engage in pilot programs through directed payments and other things like that, while you might be working on whether or not something needs to be added to a Medicaid state plan. However, directed payments going forward because of HR 1 are going to be capped at Medicare rates. This could create a challenge in the opportunity for directed payments to really be utilized in the way that states have utilized them up to this point. Again, we haven't done any analysis as to how Oregon specifically uses this benefit and whether or not it would have an impact. But to the extent you hear of or think about services that are paid through directed payments, there would certainly be some impacts there because of this cap. And again, we anticipate about between 1 and 200,000 Oregonians losing coverage on Medicaid. So, a couple other impacts I want to reference in HR1. The first, and this ties to my point earlier around commercial insurance. All of you know that we had a government shutdown recently. And the reason that we had a government shutdown is the loss of premiums that were provided to folks who qualified for Affordable Care Act commercial coverage through the exchange. As you know, in real time, Congress, there has been no solution developed to that. As a result, people receiving insurance through the marketplace, as well as other ways, are seeing increases in their premiums this year that are outsized from what you would normally anticipate in terms of coverage increases year over year in the private market. The loss of subsidies in Oregon, there's been some press reporting that approximately 34,000 Oregonians are likely to lose marketplace coverage or not opt in to continue coverage. So I highlight this because while obviously there is a lot of attention to people who may lose access to Medicaid, there is a swath of the population who might be commercially insured who is also potentially looking at losses in coverage because they cannot afford the cost of coverage going forward in the absence of those subsidies. So to the extent that providers are serving people with commercial insurance, there is another sort of added piece of the types of individuals who may no longer be able to access care through commercial coverage. And again, driving up the utilization of crisis services, driving up emergency room visits over time. The other piece I wanted to just highlight really, really quickly is SNAP. Obviously, this is food assistance and not necessarily substance use related, but SNAP also comes with very significant work requirements. HR1 creates some other limitations and restrictions around SNAP. There's a desire in Congress, to the extent that work requirements exist in SNAP and in Medicaid, to try and align those, both from a policy perspective and an administrative perspective. I name that here because, again, for vulnerable populations who might be on Medicaid and have SNAP, you could see a compounding of challenges, right? And we know that that's going to add stress to individuals and families. That's going to drive people potentially into challenges with their mental well-being. So I just highlight that because even though it's not substance use related, it's an area that's going to have challenging impacts on probably a very similar population that the substance use field serves. And so certainly it's going to add stress that may influence and inform people's acuity if they're finding it difficult to access other services. And obviously, to the extent that providers are looking to connect patients who are in substance use treatment with services like SNAP programming, it's another layer of bureaucratic administration and another layer of increased regulations that's going to impact the ability to provide those folks truly wraparound services. I have a couple other slides and then I'll pause and we'll take questions. As I noted earlier, a lot of what I just shared is some of the negative stuff that's coming out of HR1 that we think it's important for you all to be attentive to. The other piece that's coming out of HR1, however, is a new investment in healthcare services across the country called the Rural Health Transformation Program. You may have heard of this. Some of you may have seen Oregon's proposal. This is a multi-billion-dollar initiative over 5 years to expand and stabilize the delivery of healthcare in rural parts of the United States. All states were given an opportunity to apply. Every state is receiving at least some modicum of dollars by formula, and then there are some additional dollars that will roll out to various states based on other factors. The state of Oregon has received a 5-year grant of $197 million a year. Those grant announcements were just notified at the end of December. Most applications, including Oregon's, are available online, but I highlight here just the priority areas that Oregon identified in its proposal, which aligned with CMS requirements for these dollars. So there's not a ton of detail in the proposal itself to get more down in the weeds on this. But again, there are some places where behavioral health, substance use disorders, and mental illness services are identified as an area that Oregon intends to work on. So there's, I think, 5 or 6 priority areas: regional partnerships and systems transformation to look at building coordinated networks of providers and improving care access and efficiency. There's some investments noted around preventative care models, community health, and population health level issues. Behavioral health is explicitly named here in Oregon's proposal, so that's a priority area that folks should pay attention to. There is workforce capacity and resilience efforts that are noted, strengthening workforce recruitment and retention, clinical training, support for rural health professionals. Again, and these priority areas are generally the priority areas every state applied on. So just to note that these are included. This is specific to Oregon, but most states structured their proposal in this way. There is a significant focus on technology and data modernization, focusing on expansion of telehealth, digital health infrastructure, interoperability between providers to connect with patients. Again, behavioral health and substance use disorder services are named as a focal area in Oregon's proposal around technology and data modernization. So that's something that you all will want to pay attention to. And as well, specific in Oregon, there is a set aside and a priority for tribal supports, and inclusive, again, of mental health and behavioral health support services. So some of these dollars will go to support those tribal initiatives throughout the state of Oregon. Again, these dollars were just announced. States have the time pressure to put dollars out is relatively aggressive in this first year. So I would envision, and I'm sure colleagues at OHA who are involved in this are probably well aware, there's a pretty significant push now across the country for states to start rolling these dollars out in contracts, whether that's through sole source, RFPs, et cetera. So I think this commission being attentive to where these dollars start to play out, what those proposals start to look like in terms of behavioral health will be something that you want to pay attention to. So just a couple of some things just to summarize. We anticipate pretty significant administrative burden and churn in the Medicaid program because of HR1. A lot of the guidance from CMS, whether it's the work requirements, medical fragility exemptions, or some other elements of the HR1 changes, that guidance is yet forthcoming from CMS. So there's going to be some real challenges for states and state agencies and Medicaid offices to sort of find their way into implementing these as required within the timeline by law. We anticipate an increase in uncompensated care interruptions, and the crisis type services. So I think for providers who provide those services, or for all of you who are thinking about how do we best position the field to deliver care and tied to our comprehensive plan, this is definitely a series of changes that are going to create some challenges towards implementation that you'll all need to think about. Some of this as well is just going to be a burden on providers and create further provider instability. And that's absent additional revenue or other economic realities that may either prove opportunistic to support expanded providers in the state of Oregon, or to support them going forward. And again, some of that impact is not yet known. But this is going to create some infrastructure challenges at the provider level, as well as they start to see the impact of coverage changes among the populations that they serve. A lot of folks are paying close attention to the Rural Health Transformation Grant across the United States. Many see this as an incredible opportunity. But I do think what most have said, particularly advocates at the national level, is that although this influx of resources might be a welcomed opportunity to expand broad delivery of healthcare, it may not be enough to mitigate the Medicaid and other funding losses that are caused by some of these other elements of HR1. So this is going to be a period of some discord and resonance, where on the one hand, there's new resources to bring down. On the other hand, there are some changes coming, particularly in Medicaid, that may adversely impact the systems that you're all trying to build. So with that, I'm going to stop sharing. It was a lot of information. We'll have this slide deck available to all of you, but would love to just pause and see if there are any questions.
I'll just hop in and comment. Thank you, Tim. Probably should have prefaced this presentation. We wanted to bring this to you guys to start to make sure everybody has a very strong foundation and what the changes to Medicaid are going to be, so that we understand as a commission what our levers are within the state to protect people with substance use disorder and their coverage. So wanted to start with this good kind of national perspective before we start to move into Oregon decisions.
Yeah, Shira, go ahead.
Thanks, Tony. Shira here. I'm with Clatsop Behavioral Health Care in Clatsop County Community Mental Health Program. So, I think one of the most devastating things to happen to providers and to consumers is when we build new clinical programs and then we lose them a couple of years later. It's just such a significant waste of time and energy. The moral injury is awful. It creates a sense of distrust within our client population, that they can't rely on us. And so, just reflecting on burn dollars and the impact that this not very stable funding stream has had on provider organizations and communities, and knowing that we're looking at additional reduction in burn money, and also acknowledging the incredible stress and pressure that state leadership is under in trying to figure out what to do with this rural health transformation money that we know isn't going to be enough to offset med reductions. But I guess I would just ask that there be some consideration to utilize some of that money to offset the reduction in burn provider services, because I just can't, and I just thinking about losing additional SED services because of the additional burn reductions is such a heartburn. And just thinking largely about how our substance use disorder system is not sustainably funded, I guess I would really just ask that OHA leadership strongly consider how to utilize the rural health transformation money in a sustainable way to prop up SED services across the state. Thanks.
Thanks.
If I could add one other element tied to that, but just tied to decision making in general. And then Moxie, I see your question in the chat, which I can quickly answer. One other thing I will share with you all is, we've had a number of opportunities to brief various groups about HR1. And one of the questions that often comes up is, well, we have an election coming up. And is it possible that an election could come up, or there might be legislative energy to go back and sort of address some of the inherent challenges that these changes are going to cause? Obviously, you're seeing some movement in Congress to still try and address the subsidy issue relative to the marketplace. But I think globally speaking, most states are operating to think through the need to implement this as it is, and that it is probably unlikely that November or something would create a really dramatic reversal that would make some of these challenges, because as I noted, some of what's coming in Medicaid won't come until 2027, et cetera. So this is not being implemented right now. And I think we've had some conversations with groups where they said, well, if the implementation doesn't start until 2027, or this doesn't go into effect until 2028, is there the potential that that could get reversed should a federal election turn things around and Congress revisits these policies? Most states are proceeding as if that's not an option, and that is probably wise. So I just want to name that, because I do think that some of the questions around how states adapt to this need to be answered, because there isn't a crystal ball to that. The other piece I would say too is that I think at the state level, I will just speak to other states where we've spoken to state agencies, because there has not been fulsome guidance from CMS yet around implementation, there's still a ton of unknown. So it is possible that some of these impacts could be mitigated by guidance CMS gives. It's possible that there could be new negative impacts that are created. by that CMS guidance, and that is a real unknown now. So it's just another place where I think
Real
making
quick,
decisions with
real
limited
quick, Tim.
information is a challenge.
I gotta move us on. I believe we got Senator Reynolds here to present, and I know her time is precious. Just really quick, I will say that the strategy here is we got Tim national level. There's going to be some work that's done this session around HR1. OHA's got to do some work also to analyze what their response is going to be, but we'll revisit this after the session's over to get a download to see how it impacts our work. But appreciate the comprehensive overview. And we'll go into our legislative updates. Senator Reynolds, I will pass it off to you.
Thank you, Tony, and Tim, if he's still here. And my time is not all that precious. I do have something at 2, though. But thank you all. Obviously, this was mostly review for me from Tim. I'm glad you all got to hear this sobering news. And we are definitely going to be wrestling with a lot of budget issues, even pre-HR1, right? Even pre the consequence of HR1, we have a lot of issues around how CCOs are reimbursing providers in particular. And as someone who still sees patients several days a week, it's getting harder and harder to do this work and to pencil it out. So those are kind of bigger topic discussions. I am excited, though, to share with you a bill that I am presenting as a committee bill for the Senate Interim Committee on Early Childhood and Behavioral Health. And it's really aimed at trying to prevent cannabis use disorder, which our youth are at particularly high risk for. So we're calling it the Safer Access to Marijuana Act, looking at 3 issues around potency, packaging, and placement. Next slide, please. And thank you, Annalise, for setting this up. So as I said, the goal here is to prevent cannabis use disorder, which we know is a risk factor for chronic psychosis. I've shared before in several spaces that I have my brother Patrick, who's a couple years older than me, has severe chronic schizoaffective disorder. And I'm persuaded that even the 1970s marijuana contributed to the development of his life-limiting mental illness. And of course, we want to prevent cannabis misuse, unintended overconsumption of THC for all Oregonians, but especially kids. Next slide, please. So I think most of you guys know this. I know I'm preaching to the choir here that today's cannabis is a lot stronger than its predecessors, as much as 10 times the amount of THC. And I think most people aren't aware of this, and maybe they have this idea of what I'm going to consume, and thinking back to what they've seen people consume in movies or whatever it is, not realizing that they're actually consuming quite a bit more THC. And we see this both in emergency room visits, but also in escalating, I guess, getting habituated to a certain THC level and needing even more. And then, of course, we know that the frequent use and the use of these high potency products themselves increase the risk of addiction as well as cannabis use disorder, which I've touched on earlier. Next slide, please. Thank you. And here's the link between the high potency cannabis and the increased odds of psychotic disorders. Thank you. And then next slide. This is the situation where people think of cannabis as relatively unharmful. In fact, it's got the biggest gap between perceived risk and actual risk among a lot of these substances. People really are like, well, it comes from a plant, I'm just like, oh my gosh. But anyway, next slide. And this shows that when Oregon changed its packaging to allow for more milligrams of THC per package, whereas Washington did not, we saw an increase in 0 to 5-year-olds having THC toxicity presenting to emergency rooms. And then next slide. So the bill that I am proposing, and I'll be really honest, the actual bill language was sent to me Friday afternoon, and I have not read it yet. I apologize. But I've met with the drafter several times, and I think we're all on the same page. But it's the potency. So limiting the THC content to each unit of an edible should be just, oh, Christopher's read it. Christopher's here. Thank you, Christopher, my chief of staff, for 5 more days. Limit the content of edibles to 10 milligram per unit. And again, you guys probably all know this, but I always think of the gummy edibles can have as much as 10 servings of THC in it, or I think maybe 5 servings. And so, like, are we picturing people like cutting off the little feet of the gummy bear? We also want to end the infusion of additional THC into a flower or pre-rolls. I would really love to have lower potency of the actual primary product. That's a little bit challenging, and I'm available in the future if anyone here has any ideas to things that are already being grown and processed to change their actual core potency, but certainly we don't want it to be juiced up. The other thing I will say that's proving a challenge is trying to limit potency in vape. So we're not addressing that with this bill, but I would like to address that going forward. And then number 2, packaging, which is to require a single unit packaging. So a 10 milligram unit of THC should be individually wrapped. And this is again, to prevent the toddlers from getting THC toxicity from, eating, especially the candy looking versions, whether it's chocolate or gummies. And then we're really looking at this is modeled a little bit on a California bill for prominent warning labels about the risk of long-term mental health problems. And when California had a similar bill, which didn't get over the finish line, they called it the right to know. And that's really how I think about this. I think people don't realize what risk they're taking, especially young people, when if they're habitually using marijuana. And then placement is around allowing local governments to be a little bit stricter when there's compelling reason on the size and place of the buffer zones when they when they cite their stores. And next slide.
Sorry, it's not moving. One second. Okay. Oh, I think that's the end of it.
Yeah, I was going to say that might be the end of it. Yeah. So I know it's a pretty quick summary. We'll be having, some robust public hearings on this once short session starts. I did present this to my committee in December legislative days, so I'll probably just touch on it tomorrow. Will be, and I'm sorry, it's Wednesdays when my committee meets. The LCs will be filed and be part of the public record, and then we'll be dropping the bill on Friday. And I have a few minutes if you guys have questions or comments, or obviously feel free to reach out to me anytime afterwards.
Okay, thank you, Senator Reynolds. Are there any questions from commissioners, comments?
Yeah, thanks, Christopher. Christopher put my email in there, and certainly Annalise and most people, all the ADPC people know how to reach me. Yes, Moxie, great to see you here.
Yeah, you too. I just wanted to say that I can check with our ASAM chapter if you'd like any of the physicians to contribute education to the legislature or testimony. That would be really interesting to help with that. And thank you so much for your effort. I see a lot of patients with schizophrenia and schizoaffective disorder who used cannabis for many years and never knew that it was a risk. So thank you.
I know. Thank you. Thanks for all you do, Moxie. Yes, I'll reach out. Thank you all so much, and sorry to miss the second half of the meeting, but always good to see y'all. Thank you.
That's okay. And if there's anything else in your last minute you want to shout out, we need to be paying attention to. We're going to hear next from the OLCC about the ready to drink cocktails. I think that and your issue are probably the 2 biggest issues related to alcohol and drug policy, as far as I know, this session.
Yeah, as far as I've heard, I think you're probably right. Yeah, I am. I mean, on a related note, I know this isn't ADPC, but I'm looking to finally allow the state to be able to regulate the nicotine pouches as another addictive substance. But anyway, great. Thank you all very much. Take care.
Yeah, take care. Thank you. Real quick before I pivot over to the OLCC, Annalise, I know we have just some new commissioners. Can you just give a quick overview of the ADPC's purview over bills during the session? What can and can't we do? I know, we're extension of the executive branch, et cetera.
Yeah, that's a great question, Tony. And actually, a little bit of a preview for when we talk about committees later and some upcoming goals. One of the things we want to talk about with the committees and with all of you is just making really clear what's the role of the ADPC, what's the role of the commission, what's the role of the committees, and what is advocacy that happens completely outside of us. So we are a state agency, just like OHA or any other agency. And so, if we ever want to take a position on state legislation, we do have to get permission from the governor's office. We can be asked to weigh in with information without giving a position, and be neutral. And I think we have examples of where that's worked really well, where advocacy groups have moved something forward and we've provided information, but we can only actually support or oppose if the governor approves that.
Okay, thank you so much. And then next up we got John Brady from the OLCC.
Yeah, hi everybody. I'm John Brady. I'm the communications director at the OLCC, and I was asked to talk about some of the recent actions that we've taken in terms of ready-to-drink cocktails or cocktails in a can. Last fall, a group of retailers and distillers started to circulate a proposal to privatize cocktails in a can. Now, these are you see these are single serving cans. It's a spirit-based beverage, usually between 5 and 14% alcohol, so up to 28 proof. And the main tenets of or principles of the proposal would be and currently these are sold exclusively in liquor stores. The proposal would allow these to be sold in up to about 790 grocery stores. It would assess an $8 a gallon tax. So it would, right now they're marked up through our markup process. And instead they would be taxed much like beer, cider, or wine. And at the time, last fall, the rate was $8 a gallon. And the promise was, or one of the rationales for this proposal was that it would raise more money than the current system. So in November, staff briefed the commission on this. We did an analysis of the proposal, and I just wanted to provide the sort of main findings of that. One is that in fact, if we looked at how the sales of cocktails in a can between 2020 and 2025, compared how the state performed and how using the sort of main standards of the proposal, how it would perform. And what we found is instead of increasing funding, it would actually decrease revenues by about $3.7 million, or would have decreased revenues over that same period by about $3.7 million. And of course, that's $3.7 million that wouldn't be available to the state, city, or county governments. I think what we also briefed the commission on was that there would be significant administrative costs to setting such a system up, a privatized system. And at the time, we estimated about $1.2 million just to bring this under the current privilege tax system. And then there would also be staffing costs of another $660,000. So significant administrative costs. I think it's also important to note that this sort of promise of extra money was really is conditioned on a huge increase in sales. So the proposal last fall was forecasting 180% increase in the first year alone in terms of consumption, and that's about an additional $5.2 million cans of cocktails in a can, which is more than one per person in the state of Oregon. And this is just, we really think that this is an unrealistic projection. And there's very good evidence from the state of Pennsylvania to illustrate how potentially unrealistic this is. Pennsylvania in 2024 privatized cocktails in a can. Like Oregon, it also is a alcohol control state. They allowed cocktails in a can to be sold outside of their system, and again, these spirit-based cocktails in a can. And while they did see an increase, it was far below 180%. It was only a 7% increase in sales and a 15% increase in volume. So I think this promise of more funding really relies, and this is what we presented to the committee, really relies on a flawed analysis of the market. Um, a couple of other things. Cocktails in a can overall, and I think you're all aware of this, the alcohol consumption is trending down. Cocktails in a can is one of the few sectors where there is still some growth, but at the same time, there's also ex evidence that the market is saturated. And as the market has become saturated, we've found that it's starting to crowd out, or Oregon-based distillers are started to be crowding out of the market. And if we were to privatize cocktails in a can, we believe that that trend would continue. And then um, one of the final things that we presented to the committee, and which I think is of interest to this group, is that currently the control or the access of minors to liquor stores is very tightly controlled. Minors can't enter liquor stores unless accompanied by an adult. That would not be the case if through privatization, grocery stores could now sell these distilled spirits-based beverages. And so the concern is that, you would be making these, it'd be much easier for minors to get access to these beverages, not to mention it would also, you're adding over 700, close to 800 new outlets. And so you're going to strain the resources of the existing, both OLCC's compliance operations and then any other compliance operations by other law enforcement organizations. And then so having presented this on that basis, the commission decided to oppose privatizing cocktails in a can.
Well, thanks, John. And we do have our Commissioner Minty Morris also on the OLCC. Did you want to add anything?
John did a great job in hitting the most important points. I would say that if I were to summarize, I think one of the biggest concerns of the commission was just the math wasn't mathing. It wasn't a very good return on investment, if you will, to go in another direction, and that it would threaten the entire system. It was like a little step toward privatization that just didn't appear to be a good idea. The state really relies on the funding, and the places that have done it, whether it's Pennsylvania in this case or more broadly Washington State, have not had good success with it. So I'll leave it at that.
Thank you. And let's see, Julia, you got your hand raised?
I do. I still have concerns, regardless of whether it's privatized or not, that alcohol is being marketed in very colorful packages very, for kids and young folks to pay attention to and look at. However, in the marginalized communities, these things are sold in corner stores, and which brings a lot of kids, youngsters, um, homeless, houseless, rather. I need to rephrase that, houseless folks, but basically the children. They're being advertised at eye level for, same as the cannabis and the vapes and everything at eye levels for the youngsters that come into the corner stores, and the fact that they're in marginalized communities. I'm really afraid because that's mainly what a person's gateway drug is, alcohol or cigarettes. And it's just really scary that, and then the packaging that is so, and eye-catching, and they don't think there's anything wrong with it. So, me myself, I don't drink alcohol at all because I'm in recovery, but even before then. But it's just so scary for the youngsters going into those stores just to buy some candy and seeing all this other stuff that they're very vulnerable to try. And if they can't buy it, they'll steal it or whatever, right? And then it's more impactful, like I'm saying, in marginalized communities. And I just needed to say that.
Thanks, Julia. Okay, no more comments. I will move us on to April. I believe you hear from the governor's office. Talk about the recent extension, the homelessness executive order and its intersection with behavioral health.
Thanks, Tony. Thanks, Annalise. Hello, commissioners. My name is April Roman. My pronouns are they, them. I'm a behavioral health advisor to Governor Kotek. I am here to talk about the emergency order that Annalise mentioned went out on Friday, and which is an extension of previous emergency orders on homelessness for the state of Oregon. The governor first released an emergency order in January of 2023 and has since renewed it or extended it since. This year is a little bit different than previous years as we are narrowing the focus of the executive order to the intersection of chronic homelessness and behavioral health. So for folks who have not had a chance to follow Mitch's links, thanks Mitch for sharing them. The executive order text provides some specific actions this year. So building on previous year's actions of expanding shelter and housing capacity and providing rent assistance to over 25,000 households, or prevention assistance to 25,000 households, we're identifying a few more actions specifically to address the issues at this intersection. So I thought I would share some of those high level and see if anyone has any specific questions I can try to answer or take back to the team. For transparency, we're supporting the homelessness and housing initiative team under the governor's office with identifying specific actions, and then our OHA partners. Krista's here, and I think Ebony may be back or coming back soon, but are also going to be integral to what implementation looks like for some of these actions. So some of the actions that we've identified include a commitment of $20 million to what we're calling intensive PSH. So overlapping what we have as permanent supportive housing with more intensive wraparound services for folks with severe mental illness and or substance use disorder. We are working to pilot that with a couple of projects out of the OHCS pipeline to be able to identify those projects where we would have the ability to support a provider that is able to bill Medicaid and partner with OHA on making sure they're maximizing those eligible reimbursements, and then working with OHA staff to try to pair with local intensive case management teams like ACT or ICM Part of that pilot will also work to identify more of a coordinated entry system for those projects that we identify for folks coming out of state hospital or inpatient residential care. Some of the challenges now between the housing world or the homelessness services world and the behavioral health world is that there isn't a lot of intersection between those programs. So when people do get intensive inpatient care, they may not have a direct access to housing on the other side. So we wanted to try to identify the ability, this is obviously very small scale, but identify the pathway to be able to match people from those programs with a transitional or permanent housing option in lieu of the case managers are working to identify a shelter or exits to the street, right? Other actions include the metro region is actually already kind of doing this with their CCO partnership, but some of you may know about this month. I'm looking in your direction, but the Homeless Management Information System, or HMIS, overlaying data there with data from the CCOs. So HealthShare is partnering, and Care Oregon is at the table too, but partnering specifically in the Tri-County Metro region to case conference and share resources around health and housing stability. So that's an innovative thing happening there, and we're directing our teams to look at how we can best utilize that data between CCO partnership with the CCOs or COCs. Sorry, CCOs with the COCs. And I will write out all the acronyms in the chat if anybody needs help with those. And then we're also working to allocate some unspent funds into directly to residential treatment programs and supportive housing for individuals that are stepping down from residential care. So in addition to the $20 million, there's some other funding OHA has had for mental health housing that we are looking to fast track for a couple of projects coming online soon. Well, actually, I don't know the timeline of both of the projects, but we'll just say relatively soon. And at least the commitment of funds and the designs. And then we've directed OHA to explore the possibility of expanding the 1915C waiver, which is a housing and community-based services waiver for Medicaid, to be able to cover some supportive housing services, and that would help leverage existing investments in supportive housing. There are a few other states across the country that are currently using 1915C to support specifically PSH. So that is kind of exciting. And we'll see what our Medicaid team is able to recommend for us in moving forward and then expanding that. This will be slightly different than Hurston, the housing benefit, because that benefit, I believe, is attached to individuals, but this would be more attached to the housing itself. So being able to pay for the supportive housing service as a billable expense. And then also we're also looking at some of our deflection programs across the state and wanting to create more standard outcomes and measures. Currently, the programs are defining their own goals and measures for success, and we would like to try to standardize some of those so that our investments are all rowing towards the same goals. And ultimately looking at positive outcomes like housing and diversion from criminal legal systems. Those are the main actions that we have identified. They're written pretty broadly. So if any folks have, or if you have any questions, let me know, and I'd be happy to try to answer them here or get more in-depth answers for you.
Yeah, questions from commissioners? Go ahead, Shai, and then I'll get you, Monta.
Hey, April. In conversations with our local behavioral health resource network, right? So the Burns connected to M110. And I think that this is pretty common throughout the state. Again, just to kind of go back to the reduction in that funding stream. We've seen several different service providers have to close programs this past year. And so some of us are sitting with empty buildings, so we don't have operational budgets to render shelter services or PSH or, fill in the blank in the housing slash behavioral health kind of sphere. And it's unusual to have us with buildings, but not operational budgets. So I just want to bring that to your attention, that I think that that's a theme across the state, is that we have the space, but not the operational budgets, and that is existing for service providers. Just as you move forward, kind of in this work, and your thoughts around the residential expansion and the PSH expansion.
Shira, thank you for that. And I appreciate the connections with the different funding sources too. Could you speak a little bit more? Yeah, I know you said there was a Burns connection. Could you say a little bit more about that?
It's just the M110 money, right? That's the Behavioral Health Resource Network dollars, and we as in counties across the state took like 50% plus reductions in this last cycle, and we're kind of forced to close programs that we've spent the last 3 years building and getting the communities to trust that would be reliable resources. And so it's just such a shame that, like, I have the desire, I have the building, I don't have operational money to operate a shelter, right? And I know Helping Hands is in the same boat. They have a pretty big facility, I think 15 beds, and they don't have an operational budget either. So I think that it might, behoove the governor's office to do a little bit of assessing for provider organizations to see who's sitting with empty spaces and who has the operational capacity, but not the operational money.
Yeah, that's a really good idea, Shira. I know the governor's been committed to prioritizing the shelter and housing investments out of the Burns programming. And so that's definitely part of our conversation. And it's helpful to hear that there's infrastructure that already exists. And I think making sure that you all know about funding opportunities as they come out will be really important too, particularly since we're highlighting behavioral health as some of those goals for one of the first times out of this emergency order. So thanks for highlighting that.
Yeah, thank you, April. Just two kind of questions. One part is for the homeless response. Are we discussing or able to integrate the thought of recovery, transitional housing from that shelter to housing plan? I know that especially in Multnomah County, we have a challenge with funding recovery housing as one of the options, especially from voucher-based placement into other types of housing. And part two of that is just into the bigger system question as it relates to OHCS also, is like, we're trying to stand up recovery housing as part of the supportive housing network. And so we want to really keep flagging that and making sure that recovery housing is part of those discussions. I see that you have Sharon Fitzgerald now over at OHCS, so she knows a lot about that as well. So we really want to make sure we're standing that up in these conversations.
Oh, is Sharon still here? I saw her
Yeah.
around. There you are. Hey, Sharon. Manta, that's a really good question. I feel like from my days back in Multnomah County when recovery housing, you all came and testified about the importance of it, and funding kind of went in that direction. There has always been a bit of a question around which kind of system of care does it fit into, and how are we best utilizing those resources. I'll be honest, the executive order this executive order does not specifically call out recovery housing as part of that infrastructure. It is mostly focused on for that coordinated entry piece out of the SMI side of housing and residential treatment. But it is something I'm always interested in talking about and wanting to figure out. I know in the ADPC work plan we had some direction around interest in looking at recovery housing and as part of this continuum. And I know that the governor's committed to housing as a piece of the system of care, an integral piece of the system of care. And I think that we have a lot of work to do to identify how that works. So honestly, I think with SHS's passage in the metro region, there's a lot of opportunity to look at how that coordinated entry can integrate recovery housing. And I think you're one of the leaders that's well positioned to do that, knowing that you have worked in the sort of housing and homelessness world that way. But I think that I'm interested in this a lot that the data sharing piece can do as well, because I think then we're talking holistically about people's health needs alongside their housing needs, and that may help to identify other housing options indirectly, even if we don't do it formally through the coordinated entry piece. There's also, and stop me, I'm looking at Tony, stop me if I'm going on too long, but there's also, going to be a lot of interesting changes or innovations with depending on how the HUD NOFO lands and the direction to connect people to housing and treatment or to treatment alongside their housing. So I think that this is a good time for us to start talking about where those investments are in recovery housing and how it fits into that continuum of care for on the homelessness side. And I was also thinking about the state's options or ability to sort of tying in what Shira was mentioning around um, our turnkey investments, right? Because we funded a lot of projects that have transitional sort of in structure, nature of the program, turnkey investments across the state, and how we could best leverage those to fit some of these goals and needs. So it's in our thinking, but not necessarily in this iteration of the executive order. And I'm hoping that the work of the ADPC over the next year or two will help inform where we can try to prioritize that better integration.
Great.
Yeah,
Thank
before
you
I
for
move
that.
us on, I just have a clarifying uh maybe summary. So it sounds like the governor has highlighted very concretely the importance of intersection between behavioral health and chronic homelessness. The first efforts is going to go towards people with severe and persistent mental illness with housing leaving residential. And then there's a call out for OHA and OHCS to work together to look more broadly at individuals needing housing services who have both SUD and mental health. Is that right? Do I have that right?
Yeah, I think that's right, Tony.
Okay. And then,
And because when you read it, you'll see the language. We identify substance use disorder as one of those intersections for chronic homelessness. But when you look at the specific actions, there isn't anything specifically calling out a said response or the connection to recovery housing like Monta raised. So it is, but I think the opportunity in there, it is written really broadly, and the opportunity in there is around the dual diagnosis work or around the case conferencing with the health systems, which I think could be a really good opportunity for that. And for folks who are working, and Tony, you are there, and Monta, I know, but if you are working with that pilot. With HealthShare and Multnomah County, and they're expanding, I believe, to the Tri-County region. If you want, I mean, sharing updates here on that or with me directly would be great. I would love to know more about how that's working.
yeah, again, my request would be as the recovery subcommittee works to identify what our implementation plan is for our targeted goals around recovery housing, that we're included in that intersection with OHA and OHCS. I know there's been I think a mischaracterization of recovery housing from some state leadership, what it is, what it does, how it's funded, how do we define it? Is it a good thing or a bad thing? So we just want to be able to help assist in long-term strategy.
And maybe Annalise, I can punt to you a little bit on the work plan and sort of what you all are envisioning, or I know your team's here. Maybe I'm not sure which person is assigned to that, but and how that could intersect.
Yeah, and the timing is great. As we've talked about, April, the governor's office is reviewing our work plan right now as kind of everything is coming forward, the executive order and behavioral health talent council recommendations, and everything is coming together. So we can continue to talk about how that all fits together as we move forward. But I think you have heard from our folks that we feel like it is very connected. And a little bit harder to kind of say PSH recovery housing, like these are separate things. So we'll keep working through that. That's why it's part of the plan.
Okay. All right. Well, thanks, April. I'm going to move us on, but yeah, appreciate you showing up and telling us what's going on. Okay, so now we'll get into we're a little late here, but we'll get into our bylaw revision and committee lead appointments. And since we are running late, I'm just going to quickly summarize what we need to do today. We have to update our bylaws. There's one portion of our bylaws that we're unable to get into the proposal, and that's around legislative changes that were made uh, for the governor to approve the chair after I'm gone. I don't know if that means I did a good job or a bad job while I was here. I'll take the latter. But what we do need to approve today is some changes to the bylaws governing our subcommittees. And Annalise staff has worked on that. And so it's something I'd like to get approved today because our subcommittee's work is contingent on the commission passing that today. So I'll pass it off to whoever on your staff is going to lead that.
Thanks, Tony. And big thank you to Tony for reminding me this morning that we do have to update the chair appointment portion. So we'll bring that back to you. First, I'm going to do the easy part before I turn it over to Wes with committee leads. So I'll just remind folks, it was just about, in fact, it was a year ago. I think it was January of 2025, I think. Or maybe it was 2 years ago. I think it was January where we approved new bylaws. And we added for our new members, we added an entire section to our bylaws that you received in your email on Friday. Related to committees. And so it was really to just start to formalize our committees, give some parameters for membership and what the commission really wanted to see within their committees. The committees are going great. I want to say that up front. This is not because anything is not going great in these committees. The committee leads have been absolutely wonderful. Our committee members have been engaged and active and gave us more hours than we ever could have imagined to put together the comprehensive plan. But these are things Wes will go over with you for the committee amendments that we just want to have in order as we continue to work going forward. But first, the committee leads. So in the commission's current bylaws, it states that you all appoint a active commissioner to serve as a committee lead. You'll see when we get to the committee proposed changes that we're proposing that you do allow having a non-commissioner co-lead. And Katie can talk a little bit about that if necessary. She's had a co-lead for treatment, and I think it's worked out really well. But we do have just 2 changes this year that we want to put before you, and we'll do a quick vote and then move to the committee amendments. For harm reduction, Eric Davis has been serving as chair and an incredibly tough time and evolution in harm reduction. And due to work commitments, Eric is rotating off, and we're asking that Stacy, our new commissioner, step in as lead. Stacy has been a member of the committee, so this feels like a very natural transition. I think you two are the only commissioners who are regular attendees. And then for recovery, Manta was our past lead of recovery. And folks might remember we made this shift practically towards the end of the comprehensive plan because Manta is so gosh darn busy with his job right now, which was a new job that Tony stepped in as lead. So we'd like to ask for just a quick vote to approve this slate of committee leads. So I will put that out there and see if anybody wants to make a motion, and then if there's any discussion.
This is Debbie Jones. I'll make a motion to approve the committee leads as presented.
I'll second. It's Frankie.
Thanks,
Thank
Frankie.
you, Frankie. Okay.
Do we have any discussion? I want to thank Eric for stepping up and holding it down for so long. So just thank you, Eric, and also you, Manta. I know you're on a lot of other boards and committees and stuff, and appreciate you coming on and helping move the commission along in those areas. Okay, with that, I'll move us to a vote. Annalise, if you want to.
All right. So motion to approve the committee leads. Caroline?
Yes.
Thanks, Caroline. Debbie?
Yes.
Eric?
Yes.
Erica?
Yes.
Fernando?
Yes.
Frankie?
Yes.
Julia?
Yes.
Katie?
Yes.
Kelly?
Yes, sorry.
That's okay.
Had to find the mute.
Thanks, Kelly. Maris?
Yes.
Monta?
Yes. Yes.
Moxie?
Yes.
Mike?
Yes.
Sharon?
Yes.
Shira?
Yeah.
Thank you. Stacy?
Yes.
Tim?
Yes.
Tony?
Yes.
I don't think Vanessa joined. Correct. Yeah, that worked really well doing your first names alphabetical order. So with that, the new committee leads are elected, and they'll be, there's some committee members coming off and coming on. And so the slate that we ask you to approve once a year will be coming forward soon. Thank you all for serving. I will pass it over to Wes to give a brief presentation about the committee bylaw updates we're requesting.
Yeah. Hi, everybody. Name's West River, West River Senior Policy Analyst with the Alcohol and Drug Policy Commission. I'm here to provide the edits for the bylaws that we discussed just earlier. So I'll draw your attention if you have they're up here, and then also on the attached to the meeting note. We're really looking at Article 3, and this is to empower the committees to start to move the work forward, and to make sure that everything is operationally sound with the committees as they start to, as the youth say, lock in. So we're locking in on implementation, and I think you'll see that what the edits to the bylaws really try to reflect that. So I'll draw your attention to section 3.2, committee membership. We have added two clauses to the bylaws. Clause 3.25, committee members shall actively participate, disclose any actual or potential conflicts of interest, and respect others' opinions and experiences. And add clause 3.26 for removal. A committee lead may recommend removal to the commission chair and director for non-adherence to bylaw 3.25. The reasoning behind this is we are moving into an implementation space where it is very important that folks attend regularly. I think it's one of the big things that you will see, as there will be updates from organizations and from state agencies as we try to, it's a lot more linear than the policy planning process that we had prior. And so we're really asking for committee members to be as engaged as possible. And so this really tries to enshrine that into our bylaws. Again, to Annalise's point, not specific to any situation, but in thinking and taking a very preventative approach moving forward into our implementation process. Any questions about section 3.2? Okay, I'll move down to section 3.3, still within Article 3. We are adding a clause. This should, and I'm making a on the fly edit. It should be 3.31 instead of 3.3.1. But we'll make that edit for you all. A committee may choose to elect a non-commissioner co-lead from amongst the voting committee membership. So again, this is to think about in terms of the amount of work that we are going to go through over the next next couple of years, supporting our committee leads with a co-lead potentially, in taking up some of that work, and representing the commission community members who are there. We know this has happened before within committees to provide support for the committee lead. There's enough work to go around, but to support the organization of the committee, to support planning of the agenda, to support staff in communicating with all of the individual committee members. So I'll pause there, and I see Fernanda, you have a question.
Yeah, thanks, Wes. I guess my question is more around just some general ideas on what actively participate means, especially if we're allowing for removal of process. Is that more about attending meetings or the type of attendance in the meeting?
I think our staff were thinking about it in terms of attendance.
Okay.
Generally, we have not come to a situation in which we've had attenders who have not in some way participated in the process, but what we're really thinking about is not holding a seat for someone who can't come or does not have the capacity to participate in a once a month meeting, which, it happens. People change jobs, those types of things. What we really wanted to do is like, if there are so many people who want to support these committees and provide support for the commission as a whole, not holding those seats necessarily if someone cannot come. I think that is a discussion between the chair, to your point of like, what is the definition? I think that's a discussion between staff, the chair, and excuse me, the lead and the chair and the director about long lengths of non attendance. But yeah, I think that we're leaving that a little open for interpretation for the chairs and the leads, depending on what their needs are.
Yeah, right on. Thanks for the clarification.
Yeah. Any other questions? Okay, Tony, I'll pass it over to you for motions.
All right, thanks, Wes. So can we vote on these provisions today? And then Annalise will need to come back next meeting with the additional language around the chair's appointment, confirmation, whatever, and we could vote that in. Did we vote it in? It's the law around the appointment so does it need a vote or is it just an update?
So what I'd like to bring back to you guys for the chair provision. So to Tony's point, it is law that the governor now appoints our chair. So there are some internal processes in the governor's office that I'd kind of like to go through with April and Amy just to make sure we're on the same page in terms of our timeline, what our process would be in order to bring the governor a nomination for that chair position. So that'll give me time to do a little bit of due diligence, but regardless, when July comes, if we don't do anything, it is up to the governor to appoint our chair. So
Gotcha.
we've got time.
Okay, maybe we put a little provision in there. We make a recommendation or something. Gotcha. Okay, do I have a motion to approve the bylaw amendments, Article 3
Motion.
committees?
Yeah, I'd like to motion to approve it.
Thanks, Moxie.
Thanks, Moxie. And do I have a second?
A second.
Thanks, Sharon.
Thanks, Sharon. Any discussion? Seeing none, I will move for a full vote. Annalise, please.
Okay, I'm going to go through alphabetical by first name again, so everybody's ready. Caroline.
Yes.
Yay. Debbie.
Yes.
Eric.
Yes.
Erica.
Yes.
Fernando.
Yes.
Frankie.
Yes.
Julia.
Yes.
Katie.
Yes.
Kelly.
Yes.
Maris.
Yes.
Monta.
Yes.
Moxie.
Yes.
Mike.
Yes.
Sharon.
Yes.
Shira,
Yeah.
Stacy,
Yes.
Tim,
Yes.
Tony,
Sorry, I had a
Tim.
pop up. Yes.
All right, you guys are on it today. All right, that completes motion passes.
Okay, so we'll go into our general committee updates. We have 8 minutes before public comment, so I'd ask the committee leads to be brief. And I will start that process as the recovery chair lead. Been working a lot with Will. Want to thank Will a lot for helping out so much, all the ADPC staff. And our next meeting, really going to work on our charter and bylaws review, discussion on co-chair, select a co-chair, and then we've really been working on what is our strategy overview and ongoing work around recovery community centers. That's going to be a big focus. Looking at defining what they are, looking at our work plan, and really wanting to move forward quickly with that, considering the sort of unstable funding of recovery centers and how they're not really defined. So it's something we want to jump into right away. And I will pass it off to you, Debbie.
Afternoon, everyone. I think our big exciting news, and I'm glad to see that Tim's still on here, that part of the activity that the Primary Prevention Committee's been doing is to follow up with work that was passed through House Bill 3321. And Wes helped us a great deal in going through the process, the RFP process. Contract was extended to Third Horizon. So excited that we're going to be able to have Tim and his team with us for another year, and they will be helping us really make sure that we're doing that work that we wanted to, which will include inventory, almost kind of this is probably not quite the right terminology, but forensic type accounting to really know where primary prevention funding is going. And so, as we were hearing the presentations today, I think it's so important that this part is happening on that front end, so we don't continue. We can do something about that demand reduction and not as many people, hopefully down the road, needing these high-end services. So the ones who do need it the most, we can make sure and get that to them. So that's our big announcement, and very grateful for Third Horizon to continue to be on us with this journey.
Thanks, Debbie, and shout out to Tim and his team always. Stacy, do you want to take harm reduction? Is now a good time? You feel comfortable?
As I'm just silent. Well, sure. Mar, do you want to also give a little bit of an update since you've been following the
Sure,
group
yeah,
more
I'm happy
closely?
to take this if you'd like, if there's we haven't met done the nitty-gritty yet. So harm reduction will be focusing on all things naloxone coming up here in the coming months. We will also, as Tony talked about in recovery, we will be talking about our bylaws, our membership. We're looking at a name change for the committee. So that will come through the commission as a whole as well. We're putting Stacy up as the new chair. We'll potentially talk about a co-chair, all of the getting us ready to do the work. We've prioritized our strategies that were developed in the last year as the same as y'all. And so we will develop our plan for the year and go forward in that way. Stacy, is there anything else that you'd like to add? If not, I will send it over to Mitch.
Thanks, Laura.
Sorry, Mitch, did you want to
Mitch or
chime in on
Katie?
something? Or Mitch or Katie? Okay, thanks. I see. Either one of y'all.
I'll go ahead. So, for the treatment committee, we're reconvening this Wednesday, with a focus on moving from planning into implementation. So year one work will center on strengthening access to treatment across the continuum through targeted inventories and reviews, including wait lists, discharge standards, and best practices and quality measures. We'll form short-term work groups and align closely with agency and system partners on related efforts already underway. And we'll also monitor progress, funding changes, and emerging needs with an emphasis on timely access, improved transitions, and data-informed quality improvement. And I just want to acknowledge real quick that Bradley, and hopefully I say his last name right, Bukite. Did I say it right? I did? Heck yeah. So he's been serving as my co-lead over the past few months, and it's been a great experience having a different perspective on services as we shape this work.
Thank you, Katie. And then last but not least, Erica with Oh Yeah.
I think I'm going to let Wes take this. He's got more up-to-date details about the kind of budget-driven restructuring of engagement and staffing and the application. Maybe mention the application process and recruitment of youth.
Yeah. Thanks, Erica. Yeah, so we are in the process of developing a new application for the youth uh, committee. Oh yeah. That will we are losing a couple of members because they're aging out, and so we will be recruiting for members, particularly in Eastern and Central Oregon, and filling some seats that we have available for oh yeah, I think we have 4 seats available. Um, the second thing I wanted to let everybody know is we're talking on Wednesday. So our Wednesday meeting will be hearing updates around some of the work that's happening already from the youth strategic plan, particularly around education. There's a school pilots grant that everybody should get excited about that we're moving off the ground, as well as some of the work that's being done on intensive in-home behavioral health treatment. So a lot of updates on Wednesday. We hope to see you there.
Thank you, Wes. Before we move into public comment, I just want to say what a great meeting. We got through a lot of content. It was succinct. We passed some stuff, got some great information, good participation. Awesome. Thanks for our new commissioners for showing up and participating. And we are, about 30 seconds short on entering public comment, but on time. So I will open up public comment if there is any.
And no one has reached out to Mitch. So unless we have a hand up, I think we can move through to some reminders.
Great, go right ahead.
Awesome. So just a reminder for everyone, next month's meeting is hybrid. So for those who can make it, we'll be meeting in Salem at the DAS administration building, which is right across from the legislature. So since it is legislative short session, we usually like to have a meeting in Salem during that time. I will be reaching out to folks probably after Wednesday to see who can make it in person. Maybe I'll gauge interest for an informal brown bag lunch or something beforehand. That's been nice when we've done that in the past, just in a state building. So no wonderful hosting like when we go to places like Warm Springs, when people cook for us, and it's really, really nice. So maybe we'll have to do that again. So just a reminder about that. That week is also, we're kind of informally calling it Recovery Week, because I think it's maybe Wednesday. Tony can speak to this. It'll be Oregon Recovers Lobby Day. So kind of using that. My other ask of folks, we didn't get to this last month and just had too much on our agenda today. But if folks have topics you would like to hear about in the coming months or over the course of the year, please feel free to reach out to me. I think it's pretty clear we need to talk about burn funding next month, and we'll think about how to queue that up, maybe some informational about cannabis revenue in addition to that. I've also had folks suggest hearing specifically about the rural transformation funding and where that's going. And as you learned from Wes's update, we already have some nice kind of plan there with some of our work. So those are my announcements and reminders for folks. You don't have to come in person. It is very nice to be in person. The meeting will be hybrid. That's all I have, Tony.
Thanks, Annalise. Yeah, and Oregon Recovers Advocacy Day will be Thursday, February 12th. It's all day. I believe Bo's got about 500 people registered, and his goal is 1,000. And very similar to this entity, Oregon Recovers is looking at all of the entire continuum will be represented there in their advocacy efforts. So I encourage you to show up and bring people. And if there's nothing else, no burning desires, as some people say, I've moved to close the meeting
Moxie
early.
has her hand
Oh,
up.
Moxie,
yeah.
go ahead.
Just a quick question. Is our meeting, did you say, is it February 9th? Our commission meeting? That's what I have down.
Yes,
Okay.
that is correct. February 9th. Yep.
And it's just the afternoon, right? Not all day or anything.
Right. Yep. Just a
Okay.
regular meeting.
Okay, thanks.
Unless you want to go hang out in the DOS building. I'm sure it's exciting.
Sure, why not?
Okay, well, I would move we close the meeting 7 minutes early, adjourn 7 minutes early if everybody's cool with that.
Thank you all. See you next month.